Dear friends, it's really a great honor and privilege for me to introduce a very eminent personality in cardiology, Professor Satyavan Sharma from Mumbai, who is the Chief of Cardiology in Mumbai Hospital, and he's a past president of CSI. I have with me Dr. Viveka Kumar, who is the Director Interventional Cardiology and Electrophysiology in Max Heart Institute, Saket in New Delhi. The topic which we are going to discuss in next few minutes is purely on STEMI. They are the authorities in STEMI. They do a lot of interventional cardiology and clinical cardiology as well as electrophysiology. So I'm sure they are the people who are going to give a very important message on the occasion of WCC PCI 2015. Ladies and gentlemen, I welcome Dr. Satyavan Sharma, who has come all the way from Mumbai after attending ECC meeting, and he's going to give his words of wisdom on this important issue of management of STEMI. Dr. Satyavan Sharma, we see so many patients of STEMI, I'm sure in Mumbai as well as in Delhi, and at times we find there is a lot of difficulty because there is a time delay in management and there is no awareness in the patient's mind so far as the education is concerned, how to recognize a heart attack in time so that they can have a timely treatment, number one. Number two, we find even if they identify, they don't know what is the next step, whom to call. Should they call a chemist? Should they call a GP? Should they call a family physician? Or should they call a general physician? Or should they call a nursing home or a medical center or a hospital or a PCI-capable hospital? We'd like to have your viewpoint on this before we go further on this. Dr. Satyavan Sharma, sir.
Thank you, Dr. Chopra, for this very kind invitation. It's been a real pleasure for me to be here. As we all know, heart attacks have become very common in our country, and the most important thing which we need to emphasize to the public is about the early recognition of the symptoms of the heart attack. There is not much awareness about the heart attack symptoms, and the emphasis should be that if you are feeling any discomfort in the chest, any discomfort in the abdomen, any feeling of gaseous symptoms, if you are having diabetes, if you are having blood pressure, if you have a history in the family, you suspect that you are having some cardiac problem. And the patient, rather than wasting time, should immediately contact a major hospital. I think that should be the message, because as we all know, the treatment is changing so rapidly, and if there is a fast recognition of the symptoms and there is a fast approach to a center which can give you the best state of the art treatment, I think that will avoid a lot of delay in the treatment. So I think two messages. One should be on the early recognition of the symptoms, and the second should be to rapidly approach whichever is the closest center, which is a advanced center in your area, and approach that hospital.
Dr. Sharma, I think it's very important. Both the points are very well taken. But how can we increase the awareness? What kind of modus operandi we should utilize so that people have awareness? Should we use the print media or the electronic media or the digital health media? How should we educate the masses? And number two, how we can overcome the traffics on the roads, especially in the daytime or even at night when there are no technologists in the cath labs, or if at all they are there. Sometimes the cath labs are too busy. Or what we should do so that we really enhance the easy accessibility of a patient well in time to the cath lab for a proper intervention.
Said the first about how do we increase the knowledge, I think we should use all the possible modalities which are there to us. And this is the dissemination of the knowledge cannot be done by one individual or by one society. This is the one where we should involve our public representatives, the professional society, and the individuals. And it should be done by print media, it should be done by the digital media. And I think if suppose we have to look at a particular area of the city, should take the help of the elected representatives from those areas with the help of the professional society, and we should disseminate the message. Now, coming to the problem that how does the patient reach to the hospital quickly, looking to the problems of our traffic, and that is where I think the role will come of whether before a patient reaches hospital, whether we can give the patient some form of treatment, and there will be a role that you contact a doctor. And again, I think we are really still too far away from ideal circumstances. Then there should be that in every particular area, we should be able to identify that these are the hospitals which are capable of treating heart attacks. The patient makes a call there or patient approaches there, and then patients can be given either thrombolysis if there is going to be a time delay in reaching to the hospital, and if there is no time delay in reaching to the hospital, then the patient goes there straight away for a primary angioplasty.
I think brilliant exposition by Dr. Sharma. I think Satyavan has mentioned very clearly that our objective is we must have a dissemination of information about the awareness and education of the patients as to how to recognize heart attack early. Once they recognize, Dr. Sharma, you'll be very happy to know that for the first time during CSI Cardiac Prevent, we are launching an app. We took almost 4 months to understand the integrity and ups and downs of this app.
Right.
The first component is on awareness, and I'm sure we'll have many links, and it will be given to a lot of organizations which are governmental and non-governmental, even Rotary, Lions or Innerville, and various welfare association presidents. It will be given to them. And the second component is that straight away, once we see or a patient realizes that he or she had a discomfort in chest which mimics the heart attack, then straight away all the number 2 digit when they press, they will get the phone numbers, mobile phone numbers or ambulance numbers of the hospitals in the vicinity. They can click on the button, the ambulance should reach to them within 5 to 10 minutes. Once the ambulance reaches there, they do an EKG, and the EKG can be transmitted straight away by app, not by telemedicine, not by telecardiology. It will cut down the cost significantly. And as the doctor sees the app and EKG, and if there is an ST elevation MI, we can have the first point of contact. If you find there is a time delay because there is a lot of traffic on the road, or there is a time delay because the distance from the hospital is long, is more than 2 hours, then there will be second, third button where you can put a pressure under the supervision of a cardiologist to give a drug like tenioactipase, so that with thrombolysis we can salvage the jeopardized myocardium, and then the patient can be transmitted to a PCI-capable hospital, and within 3 to 24 hours he is subjected to angio and reduce the clot burden and get put a angioplasty or stenting. This app is going to be released in the Cardiac Prevent, at least first initiative. We are starting in Delhi, and I'm sure with the help of all the CSI branches, it will go in the globe. The point very well taken that early intervention is the need of the hour. We have with us Dr. Viveka Kumar, who is the Director of Interventional Cardiology and EP in the Max Hospital. Dr. Viveka, I am aware that there has been a lot of big study done in your hospital on so-called primary PCI. I really want to know, is it really a primary PCI? Because the patient reached the hospital in Delhi. I'm there in Delhi for the last 40 years now. And I know most of the patients reaching there are beyond 2 hours or 2.5 hours. I really not very sure, is it a primary PCI or not? And my second question is, what is the difference between the primary PCI and the PCI which are not primary?
Yeah, that's again a very good question. I would say that answering your first question first, that are the primary PCI in true sense a primary PCI? I would say that most of them would qualify as a rescue PCI or what we call delayed PCI in the acute MI setting, because well and truly if we look at the definition of primary PCI, they should be within 6 hours, preferably earlier the better it is. But because of the lack of awareness, late first medical contact, and we are talking about primary PCI in those patients who are just tip of the iceberg, who are reaching to a cardiologist. Remember, 98% of the population who get acute MI nationwide, they are not in contact with the cardiologist. They are looking at the physician level, and that is why we are just seeing the tip of iceberg. And large number of patients we see come with heart failures, and complication of delayed presentation of MI than within the stipulated primary PCI timeline window. And even those who get diagnosed early, as you rightly said, because the snarls of the Delhi traffic, they do not reach the primary PCI capable center well within the time. And for that, the new pharmacoinvasive data has come as a great boost, because all across the nation there is not a single place where the patient cannot get thrombolyzed and reach primary PCI or the PCI capable center within 12 hours. So I think that's a fairly good data as far as the increasing the umbrella of people who can get coverage of appropriate treatment for acute myocardial infarction. The second thing is awareness. I would say that unless the population at large and involving all the means, not only the political, I am really impressed with the mobile revolution in India, and the penetration of mobile revolution has been really better than any other country in India. So I would request CSI, you being the in charge of this app, I would say that we should involve the mobile operators, Airtel and Vodafone and all, so that they can penetrate. The biggest penetration of any if you look at the technology in India is across, I have gone to many smaller islands also. If you go to Andaman and Nicobar, there also the mobile technology is working fantastically well. So I think that's a great step by CSI to involve the newer technologies. And the mobile technology would also find out the nearest first medical contact where the patient with acute MI can go. And a lot of our general practitioners are not aware of that what should be the best possible treatment, because they forget the importance of first medical contact, antiplatelet, leave alone the thrombolytic therapy. So antiplatelet even giving in acute setting would have significant decrease in event rates. And then of course the thrombolysis and then the pharmacoinvasive strategy would be best. And the magic of primary PCI, as you said, that with the comparing the elective PCI, how different the primary PCI is. Primary PCI is one intervention which decreases the mortality from 33% to 3 to 4% if the patient comes well within a stipulated time period. So that's a huge decrease in mortality as compared to the elective PCI, which more often than not give the better quality of life rather than decreasing the mortality in true sense. So I would say that that's a revolutionary technology. The rate at which the facilities of primary PCI facilities are getting distributed all across the country is huge, but there's a long way to catch, and I think there is a huge difference between the need and the people who can afford it or who can reach these facilities. So that way I would say that the pharmacoinvasive strategy would be the way to go about. So we should educate the general physicians and the general population at large. At times we have seen people as young as in their 20s, they don't get treatment done well within time because nobody suspected an MI in those patients. So I think since the incidence of acute MI is so high in our country, we should get that anyone who gets chest pain or pain above umbilicus for more than 10-15 minutes, they should have an exclusion for acute MI, and then treatment should follow the same way.
I think the point is very well taken. Viveka Kumar has mentioned very clearly that the Indian population, we are the world capital of diabetes. We are also the world capital of MI, ST elevation MI. We are also going to be the world capital of obesity and hypertension very soon. And most of the diabetics are silent MIs, or they may have MI without chest pain. They may have breathlessness or sweating or extreme exhaustion or a dizzy spell. Very difficult at time to diagnose. I think all those things should be very well mentioned. The point which you mentioned there, pharmacokinetics approach, is the answer. The reason is, in United States, only 20% of the population have access to primary PCI. This is USA. In India, I don't know whether it's 2% or 1% or 3% of the population have access to primary PCI. I'm talking of Delhi. I don't know much about Mumbai. I don't know much about Kolkata or Bangalore or Cochin. But in Delhi, it's very difficult, really difficult. Sometimes going from my hospital to Max Hospital, that takes 2 hours to reach. So how can a patient reach? Even if an ambulance, there are a lot of dilemma. nobody can reach in 2 hours. I think pharmacoinvasive approach, there is a huge data from STEAM trial which is shown very clearly, and there's the data from Mayo Clinic and Vienna trial has shown very clearly the mortality benefit is same whether we use TNK first and then PCI, or a PCI first and then TNK. I think better to use the technology which is easily accessible, easily available, so that we salvage the myocardium and reduce the thrombus burden. That is really helpful. The second point which you mentioned is also very, very important, that app application is the answer. You mentioned a place like Andaman Nicobar, the people are using app. So I think we need to change the mindset of people. App application is the answer. Digital health is the answer. And I think that's what our Prime Minister also wants. Then we must have a digital approach to improve and enhance the heart care. I have one more question to you, Dr. Viveka Kumar. And the answer to the question is, sometimes in infarct-related artery, after even giving thrombolysis, when we see the thrombus burden is less, when we do an angioplasty or a stenting in that artery, and we find other arteries also 70% or 80% blocked or 85% blocked, what is the recommended strategy? Should we do a total revascularization, or should we do one and wait for the other one after some time and do in 2 sittings? What is the consensus today?
Yeah, so again, the Prevent PAMI trial, which showed that if you do total revascularization, that is better, but all other trials have come negative. So the recommendation as of now is that we should just touch the culprit artery unless the patient is in cardiogenic shock with other arteries are critically diseased. Because remember, the acute myocardial infarction is like a war. So you should not open up war on too many fronts. So just treat the culprit artery. By the time the patient would have adequate antithrombotic milieu based on the antiplatelet drugs, and after 48 hours to 4 weeks, we have window period where the rest of the arteries can be reassessed, and it can be reassessed by either FFR if they are not very critical, or we can, if we have done well within time period, the angioplasty primary PTCA, then we can even do, stress MPI, stress studies, stress echo study, and based on the ischemia, we should revascularize them. Now we had in this conference a lot of talk about non-invasive FFR by CT angiogram, so we can take the help of those technologies also, because there is a data that those arteries which are not hemodynamically significantly stenosed, there is no added advantage of revascularizing them. So the recommendation as of now is that treat the culprit artery unless the patient is in cardiogenic shock with critical lesion in all other arteries, and the other arteries should be re-evaluated and revascularized after 48 hours to 4 weeks time period.
Very nice. I think Dr. Viveka Kumar has mentioned a very important point. He said we already have one front, we are having a war. Why to open 2 fronts? And on the contrary, if there is a cardiogenic shock, there is a third front. I'll ask Dr. Satyavan Sharma, what should be the approach when we have 2 front or 3 front? Should we follow the strategy what Dr. Viveka Kumar is suggesting, or if there is a cardiogenic shock, we should even open the third front also?
I think I will completely agree with what Vivek said. If a patient is having an infarct, open the infarct related artery, and for the other arteries, choose the appropriate time, either by doing ischemia testing or by the anatomical severity. Now, if there is a cardiogenic shock, I think this is a completely different ball game. And in patients of cardiogenic shock, for stabilizing the patient, whatever amount of maximum revascularization you can do, you should do. So, cardiogenic shock, certainly, if you can open multiple arteries, you should go for that. Of course, infarct-related artery first, and then the vessels which are supplying a large amount of myocardium, and then the one which may be the least productive.
So there is a very clear consensus by both Dr. Satyavan Sharma and Dr. Viveka Kumar, who are a very eminent interventional cardiologist in India, and they mentioned very clearly and very categorically that deal the infarct-related artery first. The rest is all secondary. We all can see those fronts later on. We can do all kind of tests to see the viability. Either we use the non-invasive modality or the invasive modality, and based on that, one can go for perfusion deficit or a viable or non-viable myocardium, and can perform the procedure from 48 hours onwards up to 4 weeks, depending on the need in those patients, which is a very important message. And the second thing, I think both the learned speakers have mentioned very clearly that approach in a setting like India, we must try pharmacokinetic approach. But if a person in the very close vicinity of a PCI-capable hospital, the first option should be PCI, primary PCI. But if the time window is delayed, I think it's better to go for a second option. And we must have an education to the physician or general practitioners so that they also don't misguide the patient. Sometimes, the patient, by the time they go to an interventional cardiologist, the cardiac status is already crippled. The ejection fraction dropped down to 35% with a huge damage, and there is an aneurysm of the LV, and that time they are going to a interventional center. I think it's too late. So we need to enhance the awareness because it has got a medical legal implications in the years to come. People will watch the time from the hospital, home to the hospital, and then hospital up to the ECG time, and from the ECG to the door to balloon time, and then from how much is the difference? Because these lawyers are going up to this extent now.
Yeah.
There is a case going on in MCI. They wanted to know exactly from the medical record what time the patient came, what time he entered in the hospital, what time his file was made, what time he went to cath lab, what was the opening time, when the machine was started, when the technician came, because it has got a lot of influence on us. So to overcome this problem, I personally feel pharmacology approach is much superior. At least one modality of treatment has been instituted, and by the time we come for a second treatment, and it is a must. Every patient has to have angio. Every patient may need angioplasty. But I think in a stepwise manner is always better. I think both the doctors have done a wonderful job, and I'm sure I like to ask only one more message, that we are here in a spiritual ambience in this conference where we talk of preventive cardiology a lot and a clinical cardiology a lot. Do you think, Dr. Satyavan Sharma, preventive cardiology has the role in interventional cardiology ahead? Or you find interventional cardiologists are different and preventive cardiologists are different?
No, preventive cardiology has a tremendous role. In fact, I feel very strongly preventive cardiology is a bigger need of the country. Ultimately, both things have to go. We need to treat the patients who are already there by the best possible modalities, but we need to prevent a large population which is on the threshold of getting cardiac problems. So preventive cardiology certainly is the need of the hour, and all of us, of the society, professionals, public, politicians, our public health foundation, and all the allied professional bodies should be for prevention. There is no question about that.
Dr. Viveka Kumar, do you agree with
sir.
Satyavan Sharma?
I fully endorse his views, and I would say that I'll quote a study where myocardial infarction and coronary artery disease at large was seen as a disease of lifestyle. If you look at that paper in Lancet, that showed that it's a disease of lifestyle, and there is no better way of preventing or correcting the lifestyle than going by preventive cardiology ways, and not only improving the lifestyle but also combination of preventive medications. So there is a lot of role of molecules like antiplatelets, statins, ACE inhibitors and beta blockers, not only in primary prevention but more importantly in secondary prevention also. So I fully agree that the stress debusting and the stress modifying strategies which is there in centers like our Shanti one, that should be propagated, that if you de-stress yourself, because we've seen young acute MI patient does not have any plaque, it's just the acute thrombus, and that could be because of the stress and because the smoking, because the prothrombotic milieu which he creates acutely. If that acute moment of prothrombotic milieu is prevented, I think our job is done. So there is no better way of intervention, though the preventive cardiologist looks non-interventionist, but I think in our true life that is the biggest intervention, and that takes a lot of courage and motivation to intervene to decrease the event rates of acute myocardial.
Well spoken by Viveka Kumar that so-called preventive cardiologists are the real interventional cardiologists. They need to intervene first before they come to the mechanical interventional cardiologists. I think that's a very right message because intervention is the answer. And he also mentioned a very important point, so-called the milieu interior. What we are doing here is integrating the milieu interior with the milieu exterior. There should be optimization of a milieu interior and milieu exterior so that there is an equilibrium. When there is equilibrium, we create a perfect environment for a healthy heart. And if you see the theme of World Heart Federation this year is the healthy heart, healthy environment. When we talk of environment, it has to be internal environment, what we call the microcosm, expressed by Viveka, and the external environment, what we call the macrocosm. So they have to integrate, and as a microcosm, so is the macrocosm, because the macrocosm influence through the mind the milieu interior of within us.
Yeah.
And I think, as you mentioned, we don't see any plaque, we don't see any ulceration in the coronary vessels. It is just a thrombus which is formed suddenly because of chemical imbalance which is occurring in the milieu interior. I think the point is very well taken, and I think the opening of preventive cardiology is by interventional cardiologist. You'll be very happy to know that for the first time the CSI Cardiac Prevent chairman is an interventional cardiologist. So this is something very great. And Dr. Satyavan Sharma was very categorical and very straight that preventive cardiology role cannot be overemphasized. Preventive cardiology is required everywhere because even Satyavan Sharma is a part of preventive cardiology, because when we talk of preventive cardiology, it's primordial, primary, secondary and tertiary. And Dr. Satyavan Sharma or Dr. Viveka Kumar, they are the experts in tertiary, no doubt about it. But after the event is over or after the intervention over, they have to come to secondary, primordial and primary prevention. Ultimately, they are a part of it. Without this, the patients cannot survive. So as a whole, I think if you see, preventive cardiology has much more higher proportion as compared to interventional cardiology. Interventional cardiology has a huge role. It's a panacea during acute emergency. There is no doubt about it. It's a wonderful technology which has got a huge potential. It saves so many lives. It's a life savior in acute emergency. But the time factor is very, very important. And timely intervention is very important. And the expertise is very important. I'm sure, Dr. Satyavan Sharma, you would like to speak few words about the expertise. Who are the best people? Who are the real people to do interventional cardiology as compared to those who are new trainers and they have no idea, but for vested interest, they keep on doing intervention, and how much is the benefit? I have no idea. You can express on this.
Of course, interventional cardiology, the field of angioplasty and acute myocardial infarction has considerably grown in our country. No question about that. And after DM cardiology or DNB cardiology, when the persons are coming, they are working in good centers. I think initially it may be a good idea for a young person who has qualified his exam to work under some senior, get a little more training, refine himself, and then start doing the procedures. I think proper people who are properly qualified, people who have worked for some time in much high volume centers will be the best people to do the intervention, because the acute myocardial infarction interventions require little more understanding, little more skills, and a different approach than the approach in the stable patient. So that's what I will say.
I think, do you agree with Dr. Satyavan Sharma?
Yes,
we need more skill and more experience and more patience and to do things independently?
Yeah, absolutely. I think in today's talk also had shown that complication rates and mortalities are much higher in acute MI interventions. And when you look at the newer cath labs and newer so-called not so trained interventional cardiologists, their bread and butter or majority of cases are acute MI events. And there we have a data analysis which has shown that the newer centers with newer cardiologists, the complication rates and mortality in acute MI intervention is much higher compared to an high volume center or high volume operator. So I would say that, as fully endorsed Dr. Satyavan Sharma's thing, that there is need of the hour that there should be more collaboration with the, so newer centers should be, attached to a high volume center so that the quality is monitored. And it's high time that, apex body like CSI also comes with some kind of data entry and self correction, so that it is in the interest of the society at large, because unless we audit our own data, we are not going to give better results. So I think it's not the inexperience or anybody is against people using opening up new hospitals and doing intervention, but it's the basic ethics and basic tenet of medicine that the complication rate should be decreased and the society should be served at large. And for that matter, I think most of the centers should give their data and show how much is what is the door to balloon time. Now if you in US, if a private hospital goes for registration, they need to show these data, that what is all their quality index, and the quality index should be monitored by each cath lab as far as the interventional cardiology is concerned. And the rating, in fact, a lot of insurance companies are not paying as much as to the hospitals do not have good record, they don't get paid in the same proportion as the hospitals which have got good records. So I think this is very important for in that respect also, and that's the way to go about in future. And as you rightly said that we need of the hour is to have more centers, but we should not have more centers like our traffic is happening, that the more cars and more accidents and more lives, so rather than making the life easier, they are causing more deaths. So similarly, we don't want that in order to explode the need for the newer centers, we should have increased mortality. Their purpose is to decrease mortality. So I think controlled growth is the way to go about, rather than having exponential uncontrolled growth in intervention setups also.
It's very nicely said by Dr. Satyavan Sharma and Dr. Viveka Kumar that it is the training and competency is very important and not a competition. I think it's the competency which plays a very, very important role, and there should be some kind of regulation on the competency and and there should be some kind of regulation on the training. And CSI should take a lead because it has got a huge medical legal implications. Overgrowth, oversaturation, and over issues from the vested gains may create more problems, may create more accidents. I think I totally agree that we must have some regulation body, and there should not be any medical legal implications subsequently if the person is adequately trained. I'm very happy that we got all the information from Dr. Satyavan Sharma and Dr. Viveka Kumar in the interest of managing STEMI in India, and I'm sure in the years to come we can manage it well. Thank you very much, Dr. Satyavan Sharma, for being with me, and Dr. Viveka Kumar for your wonderful expression, and I'm sure it will take an action in the next few months or few years in reality.
Thank you.
Thank you very much.